Hello, everyone. Happy holidays. I'm Michael McNutt, VP of Education and Marketing for Weedy, and welcome to How to Leverage CMS Interoperability Rules for Prior Authorization Innovation. Before we begin, just a quick reminder, question and answers are done non-verbally through Zoom's chat feature. It's now my pleasure to introduce Jason Amaral and Brad Smertz with Cohere Health.
Perfect. Hi, everyone. This is Brad Smertz, Director of Product Strategy at Cohere Health. A pleasure to be with you guys today and looking forward to digging in on this important topic. Jason?
Morning, everybody. This is Jason Amaral. I lead interoperability strategy here at Cohere. I've also been recently appointed to a steering committee seat at the Da Vinci working group. And I'm excited to talk about one of the topics I'm really passionate about.
All right. Just to kick us off, I know there's probably a variance in terms of familiarity with Cohere Health in terms of attendees on the call, but wanted to start with sort of some basic metrics just to illustrate who Cohere Health is. So Cohere Health is a digital health company looking to automate the prior auth process. And so when you look at sort of our scale across the country, our solutions and our partnerships with our health plan partners cover about 16 million lives across all lines of business. Pretty broad provider network of over 550,000 unique providers. And then on an annual basis, we have just about 10 million authorization transactions being processed through our systems today. We are live in all 50 states, of course, HITRUST certified, NCQA and URAC accredited. And sort of the impact that you'll see that our solutions can have. These are some of the sort of top line key performance metrics, but we do have a significant sort of amount of digital adoption in terms of the percentage of authorization submitted through a digital channel. Varies by specialty, but on average, 94%. A lot of our impact that we can have, we want to make sure the patients are getting the right care at the right place at the right time at the right cost. And so the approach we take to sort of impact is unique in that over half of our impact is actually non-denial based. Third here, we do automate a lot of the process along the way. And so that results most importantly in faster care for patients, about 70% faster care. And then our platform is sort of intentionally designed to enhance the provider experience. And so you'll see that we do take national surveys of our provider network, and we get 93% that are satisfied or extremely satisfied. With that, I'll turn it over to Jason for this piece.
Yeah, so we wanted to start off today with a little poll to get a better understanding of where the audience and some of your organizations may be along your compliance journey. So the question that we're prompting you with is, how far along is your plan on the compliance timeline for CMS 0057F? If you wouldn't mind replying in the chat with one of those numbers that are behind schedule, catching up, on schedule, or ahead of schedule. Let's give you all a couple of minutes to reply. All right, starting to see some replies. All right, great. So it looks like some of y'all are either behind schedule or on schedule. So what we wanted to talk about today is how Cohere is enabling our intelligent prior auth solutions to meet some of the requirements that have been laid out by the CMS 0057 regulation. So as we all know, the CMS rule has been finalized and published that allows that will require plans that are either Medicare Advantage, Medicaid, CHIP, or QHPs to enable prior auth access and interoperability standards around FHIR specific standards. So Those solutions will basically provide access to either logic or data sets that are currently housed in payer systems today. It also requires transparency around turnaround times. So how long an authorization took to determine, what were the denial reasons for a given authorization, and then specific metrics around prior authorizations, decisioning essentially. We tend to break these up into four separate pillars. So the different areas of focus areas of the regulations that we sort of narrow in on are interoperability, where we know that the standard of the FHIR implementation guides that have been laid out by the Da Vinci working group have been sort of surfaced as the method in which interoperability will be enabled for all of these downstream and upstream systems. For turnaround time, we now know that regulations with decisions within 72 hours will be required for expedited cases, and 7 days as a total for standard requests. And then a level of transparency is now required around authorization requirements and decision rationale. So a lot of we'll get into this a little bit further later on, but a lot of the requirements on how an authorization should be decisioned, what was the rationale in rendering that decision, would now need to be surfaced through several APIs. And then lastly, accountability around publication and reporting of auth requirements and policies that align with sort of those guidelines that are laid out by the regulation. We accomplish that through different layers of reporting and also, again, surfacing that through specific API endpoints. So specifically around prior authorization, so we're going to narrow in on what the prior authorization requirements are for authorization submission, authorization documentation requirements, and surfacing statuses up to external systems. So the requirement specifically calls out that the health plan would be required to build and maintain a FHIR application program interface or API that would share the list of covered items that require prior authorization, what documentation requirements require prior authorization, decisioning logic, essentially what would lead to an approval or a denial, and then what will support these transactions for a provider and patient. So essentially ensuring that the endpoints have a level of stability and reporting around them so they are interchangeable and usable with any external system. We lay this out sort of in a data exchange model. So for the folks who may not be too familiar with the 3 components of the prior auth endpoints, basically on the far left from a provider standpoint, there would be an inquiry either from an EHR or an external system that provides prior auth request data. So that could consist of member information, procedure information, and provider data. That would then hit an external endpoint for a response, simply stating whether or not a prior auth is required. So that first pink box that you see under CRD, basically outlaying whether or not an auth is required and what those requirements may be, which would then result in a response to launch a DTR experience. Essentially, what are those requirements listed out in various number of ways? Cohere solves for this with the smart application, which surfaces clinical questionnaire and clinical data exchange methods in that smart application experience. Ultimately, what that results in is a prior auth submission in the FHIR standard that will end up in an external system, generally a UM, sometimes a claim system within a payer's IT infrastructure. We also wanted to highlight, so that is the data exchange model. In theory, happy path scenario, as we like to say, if that is always the way it worked, it would work great. But essentially, the complexities behind some of this are things that we have learned over the years at Cohere, surface up during implementations or during designing and scoping these solutions. And a lot of that has to do with the information that we are building these solutions on top of. So whether or not that is data sets that are disparate, separate from existing systems, have to be sort of consolidated, cleaned up, and surfaced to external systems, whether that is the ongoing management of those prior authorization requirements. So how are we surfacing up whether or not an auth is required or not by a specific line of business, by a specific group for a given provider? A lot of those complexities are not only spread out through multiple systems, but they also change very frequently. We have a recent example where we had over 10 changes in a given week for one of our plans, and that was in order to specifically support exclusion to prior authorization requirements and the rules used to make that exclusion rule work in our system. And then ultimately updating and managing medical policies in that solution. So under those requirements, they are backed by medical policies, whether that is through a third-party vendor, whether that is policy that Cohere has developed, or those are policies that are organic or native to the health plan. Those policies are configurable and managed by our operations team on an ongoing basis. So those complexities are sort of the underlying components of how the interoperability would actually function. Otherwise, we're just standing up endpoints on top of things that don't have much logic behind it. So something that we have learned, again, over the years of implementing these solutions. So now that those are the requirements and some of the challenges that we kind of outlaid through those last couple of conversation points, I want to talk a little bit about how Cohere solves for those solutions with our intelligent prior auth solution. Addressing kind of the 4 pillars that we discussed, the interoperability solutions, Cohere currently has live in production the CRD, DTR, and PASS components of the CMS requirements or of the DaVinci solution. So that would support auth submission, requirements sharing, and data gathering through the Smart application that has been externalized and is used by several systems and several partnerships that we built out, both EHRs, connected EHR applications, and downstream many multiple utilization management systems. We've addressed the turnaround time requirement by providing real-time clinically appropriate automated decisions that result in 50 to 90% of authorizations being auto-approved. So these are solutions that, these are decisions that are rendered within our application, and the user receives that decision real time. It has also been externalized through our endpoint. So if we can render a decision with the information that is submitted via a PASS submission, we can respond real time with that, with the logic we built on top of to render an authorization decision. From a transparency standpoint, all of those requirements check the triage of those, the actual checks, the administrative, as we call them, nudges, and decisioning reasons are all surfaced to the user real time within the platform. So for example, during the prior authorization submission experience, there are a number of interactions that the user may have with many of our automated systems, whether that is a rule that is firing on the initial member search, stating that this authorization does not require prior auth based off of the member's coverage, whether that is during the provider search, if a given provider is excluded from prior authorization, or if there are policy-based nudges that will state changing a place of service could result in a different decision or an auto approval. Those are all solutions that we use to sort of guide the user through authorization submission in a transparent way. And lastly, we have a robust data and analytics layer that surfaces up the requirements around turnaround time, around the productivity of a given authorization group, if you will, and then how specific services are or not performing in a given policy area. So just drilling down a little bit more into the interoperability use case, as I mentioned, the DaVinci PASS solution is what we are using for auth submission for multiple systems today for our payers. It is a real-time FHIR integration where we are sending upwards of several million transactions over a year that submit a PASS solution to downstream systems. And then we also utilize PASS as a way of kind of continuing the auth submission process. So if you think about it as an authorization has been submitted, Cohere has not been able to render a decision in an automated fashion, then we would prompt the user in an external system with a DTR solution to either request more information, retrieve more information, or just kind of continue through the pended auth status to a decision auth status. And then the most externalized and kind of accessible solution here is simply just the CRD that any system can ping for our payers that can give them significant amount of information around whether or not an auth is required in the context of a procedure, diagnosis, the member information, anything that sort of is sent over that submission would trigger any of our backend systems, again, built off of the policy and the requirements of a given payer. So we're going to start to talk a little bit more about our approach in the intelligence space and how we are rendering that decision and the logic behind it. Just hand it back over to Brad for that.
Awesome. Thanks, Jason. And I'll just mention there will be sort of a dedicated Q&A session at the end of this set of slides. So looking forward to your engagement. Feel free along the way, if you have any questions on particular pieces, you can drop them in the comments box, and we'll make sure that if we don't address them live, make sure that we address them during that Q&A session. So perfect. All right. So zooming out a little bit, and I think Jason covered the CMS sort of regulatory requirements well, and how part of our solution is sort of designed to address that. But wanted to also think about, that is a very critical part of the set of capabilities that a health plan needed to automate the prior auth process. But, that's one of the many things that Cohere has developed to help, deliver value to patients, providers, and health plans. And so wanted to zoom out a little bit and show you guys sort of the broader set of capabilities and solutions that we bring to the table, including the sort of, the items that are needed to address the regulatory requirements. And so when you think about, this is an oversimplified flow, but when you think about sort of the end-to-end flow of the prior authorization process, Cohere does have solutions that sort of, drive value at each step in the process end to end. And so when you think about the first step on the left, intaking the transaction, so intaking an auth, digitizing it, determining if an auth is required, doing member eligibility checks, provider network checks, that type of thing. We can do that from an omni-channel perspective. So it's very flexible, where we have a web-based portal that we can offer. We can also implement what we refer to as sort of a headless model, where if you already have an existing portal, we can just be the intelligence that sits behind it. We have multiple points of EMR connectivity. We have fax automation software that you can use to improve the efficiency of intaking faxes at your organization. And then any phone auths can be plugged into our platform as well. So all those auths get sort of digitized through a single digital layer, where we begin to implement our clinical intelligence. And so the first step is doing what we call a completeness scan. So basically we have AI document segmentation models that take the documentation requirements for the given policy based on the service. So this is where DTR comes into play. We take those document segmentation models and scrape the document, reconcile against those documentation requirements, and pre-submission surface those insights to the user to say, hey, we were looking for five of these items. We only found these 4 to support a complete submission. Please include this additional item, basically. And so it is a soft nudge. They can accept it or not, but do want to be as transparent as possible with the provider to make sure that we can reduce that missing information back and forth between the parties. The second piece, once we have a complete submission, we can run our automated clinical review engine. So there's a subset of cases where, depending on the specialty, but usually between 50 and 80% of cases, we can actually fully automate a clinical review and generate a clinically appropriate auto approval real time. And that's not using questionnaires, but using a proprietary sort of layer of AI models that go in and actually read the clinical note, read medical and pharmacy claims, other historical data such as auth information, even basic demographic information from the member file, reconcile that against medical necessity criteria and automate the determination. If we can't automate an approval real time, we do want to provide the tool set to the nurse and MD at the payer to say, hey, let us show you where the machine left off. If there's 10 criteria we needed to find, we only found 5 of the 10. Here are the 5 out of 10. Here's the evidence that supports it, and so forth. So it's a AI-assisted review that's meant to improve review quality and review efficiency, drive consistency in that review experience. And then lastly, there's this whole sort of solution set is flexible. It's sort of designed to be modular by nature. So, whether that's just going with sort of those DaVinci APIs to meet regulatory requirements, certainly an option, all the way from that to we have a number of health plan partners that typically want that plus, intake and decisioning and AI assisted review as well. And so we've kind of, again, built it to be modular so that it can sort of meet you where you are and then also support your sort of growth path and strategic objectives. So, I kind of touched on this on the previous slide, but I think the beauty of this technology, it's funny when we kind of do demos, the demo of the portal experience itself is nice, but a lot of the beauty of the solution actually happens behind the scenes. And so this is intended to sort of, kind of look behind the curtain and articulate, the sort of advanced technology and AI techniques that we use to actually automate decisions at a high quality level at a high rate. And so we call it our clinical intelligence layer. We use this across all of our solutions, our platform. Basically, it's AI and ML to automate the approval of clinically optimal care. So if you think about the market today, this is sort of broad strokes, but on the left, we're coming from a place where we call it level 0. A lot of the decisions are being manually reviewed by RNs and MDs, but many of those decisions, actually most of them, are ultimately being approved. And so, I think in the industry we said to ourselves, hey, if most of these cases are being approved, there's like a subset that are very obviously meeting medical necessity. How can we use technology, best-in-class technology, to actually automate those determinations real time to make sure that we can get the patient the care sooner and kind of get out of the provider's way? And so the first step in that evolution, I think, was we call it user input-based rules, where I'm sure you're all familiar. We call it clinical assessment questions, but it's called different things in the industry, where you're surfacing 10, 20 questions to a provider. They're answering, usually it's an administrative staff member at the provider practice. They're answering those questions. It gets fed into a basic rules engine. And then, you can have an opportunity to get a real-time approval. So we actually built that out at scale and did very extensive audits across a number of different service types. And what we realized was there was a good degree of inaccuracy in the decisions being made. And it wasn't necessarily because of the sort of content or the algorithm, but it was because I think the information being provided by the administrative staff at provider practice was often inaccurate and not corroborated by clinical documentation. And so a lot of the time, I think it comes down to there are multiple reasons why that can happen. There's some gamification, but a lot of it too is we're asking sort of an administrative staff member that maybe doesn't have the clinical training necessary to answer very nuanced clinical questions. And so we found on the order of 20 to 30% false approval rate being generated by those types of decisions. And so we a couple of years back invested very heavily in the concept or the thesis of we have all of this patient information already. Why can't we use cutting edge technology to actually automatically pull that information, sort of normalize it, and then use that information against the policy to automate a determination. So most of our decisioning, actually really almost all of it today, is in this level 2 bucket, where we're taking our library of proprietary ML models that are hand labeled by clinicians and applying those. Those are models that go in, read the clinical note, even unstructured documentation, pull that information, map it against the policy, and make a determination of whether it's met or not met, referencing that longitudinal patient record. The second piece where we've invested is predictive. And so we don't do predictive decisions, meaning all of the decisions for medical necessity are being made by this level 2, where it's deterministic against the policy. Predictive is being used in other ways across the platform to predict maybe risk score for a patient, to inform site of service nudging and things of that nature. And so those are some of the sort of early sort of predictive models we've deployed. And then lastly, we're investing in level 4, we're calling value-based, which is actually not only predicting something might happen, but also determining what is the next best step or next best action, including episodic auth. So offering sort of began to offer sort of bundled episodic authorizations for certain services, so we can kind of sort of incentivize the right care path forward. Awesome. And I think it's important. There's a lot of talk about AI. It's kind of a buzzword in the industry, but wanted to sort of give some substance around how Cohere thinks about AI. So when you think about AI in the prior auth process, there's sort of 4 key principles that we think about across the board. And so one, really important that there's accountability. So we have, I think the only reason our solution works is because there's clinicians behind the scene that are hand labeling models. They're monitoring the performance of models, ensuring that we're getting very crisp on the interpretation of the model on the clinical record and so forth. So we have a team of over 150 clinical experts that in the initial development process and then also in post-deployment are continuously monitoring the performance of those models, ensuring that they're behaving the way that they would expect a clinician to behave in terms of interpreting the documentation. So always grounded in evidence-based practice. Second is I think this is just as critical, which is transparency. And so we've actually invested a good amount of resources in even for internal and external purposes, ensuring that every single decision that is made, it's super clear to the user, whether it's internally or externally, why that decision was made. And that makes it traceable, makes auditing easier and things of that nature. So make sure that those decisions being made are not in a black box. And we also want to be transparent with the provider upfront as well, what we would expect from them from a clinical documentation perspective. And that's, again, part of where DTR comes into play. Privacy and security. So from a privacy and security standpoint, to maintain privacy and security, our AI models don't use explicit identifiers for patients. So things like name, location, providers, and so forth. So that's pretty table stakes. And then lastly, definitely a big focus on inclusivity and equity. So our models do leverage a variety of policies and clinical experts that review pending requests. And they since they're trained by our clinicians are trained to apply an eye towards inclusivity and equity across a plan's entire membership. So that can include SDOH factors and things of that nature that are baked into sort of the AI algorithm. And then principally the last piece I'll mention outside of this framework is that we never deny care, auto deny care. That always requires a human review. So just principally we'll never automate to denial ever. It's simply using automation to get to a yes sooner. That's the goal. So some of the sort of proof points here, not comprehensive, but just to give a sense of some of the impact that our solution has had. From an intake perspective, we've driven down the time to submit an auth by about 44% because we can remove those clinical questions from the process almost entirely. And that's typically about half of the time spent by a provider practice submitting an auth is on those clinical questions. We've cut the amount of requests with missing information in half by doing those, implementing those proactive sort of completeness scans and nudges to the provider. From a decisioning perspective, we've achieved almost 90% immediate auto approval. Again, that varies across services depending on cost, complexity, and so forth, but on average, 89%. And then we do offer sort of site of service and other nudging to sort of nudge towards that optimal care path. So we've gotten 30% acceptance of those nudges. And then from a review perspective, we've for the cases that we can't get an auto approval on, we cut the manual review time by 25%. Awesome. So I think we wanted to wrap up with another question here before we get to the general Q&A. if you don't mind. Similar to the first question up front, if you don't mind entering responses, we're curious, which aspects of aligning with the CMS rule pose significant challenges to your team. And we've provided sort of five response options. So I'll give you guys maybe a minute just to answer, and then we can take a look. Awesome. Okay. Thanks, everyone. Appreciate the engagement. And so I think to wrap up here, wanted to make sure we saved a bunch of our time here for sort of a live Q&A. I think that we find that it's typically sort of the more valuable part of the session for the attendees. And so I know we've gotten a number of questions in the chat throughout, so maybe we can start going through those, and then we actually got a number of others to cover as well. So if you have any additional questions as we go through, feel free to post them in the chat. But with that, I will actually turn over to Jason to start working through those questions.
Yeah, thanks, Brad. One of the questions that we got was whether or not Cohere was actively working with physician or health system organizations to access the prior auth support APIs. We are, to kind of answer that, Cohere has taken an approach to partner directly with either EHR vendors or EHR partners who have established solutions in a given EHR. So for example, Epic Payer Platform is a solution that we have launched that would work off of referrals or orders workflow to both submit authorizations, check authorization requirements, and we're working to sort of continually enhance that to be fully compliant with the CMS standards. We also worked with partners who already have systems established in the Epic integration solution. So if they are listening in on an orders feed, for example, we are simply transforming that into a prior auth submission and replying back with a decision or instruction to provide more information. The other question we got was around whether or not Cohere was implementing post-pass API via CAL/CDEX. So another way saying this, sort of, if I understand the question correctly, is how we are facilitating clinical data exchange. Are similar to the previous response, we are working directly with the source of truth, in this case, the EHR, who is hosting clinical data exchange, to proactively prompt the user for that information or proactively pull that information during the prior auth decision. We are not specifically implementing CDEX, but what we are working towards is getting enough clinical context to render a decision without any user follow-up. And that sort of very consistently aligns with how our platform works as a whole. We work with, for example, clinical data that we already have based off of prior auth submissions, or if we have claims information, we can limit as much user interaction as needed to render a decision. Question from chat about questionnaires. So the clinical questionnaire and how we surface that today, kind of different approach than I think what we've heard out there in the market, is that we are working to limit the questionnaire questions to only the context that is needed to render the decision. So for example, if one of the questions is the patient over the age of 60, or has the patient received this prior procedure in the X number of days, we have that clinical context in our system already, either from claims information or from, again, prior auth information that we have already received. So we can sort of pre-fill or understand what clinical questions only need to be answered. We are working to categorize those into different groups that would align more with CQL. But what we're trying to do around concepts of both CDEX and CQL is move at the market pace, so we are not too far out ahead of where people are in adopting that technology. In other words, when we are able to successfully retrieve information after prompting with a group of policies that are grouped in CDEX format, for example, we would implement that at that time. And another question is whether or not we had time to consider an impact of the proposed rule guardrails for AIs impact on our solution. Impact as in whether or not it will be affecting our current technologies. I would say that we keep our eye on updates both at the state and the federal level to ensure that our platform is compliant. The AI solutions that we have significant amount of AI safety provisions already built in. Brad, I don't know if you want to talk a little bit more about sort of our technology stack and how that would work under regulatory means, but specifically not too much around the guardrails for AI from what I can recall.
Yeah. So based on previous guidance, I know there was that new sort of proposed rule that was included some guidance around guardrails for AI. Our team has actually been actively evaluating that, and all indicators so far point towards our existing technology stack and approach sort of adhering to those guidelines. Certainly previous guidelines, I know almost it seems like every month there's like new updated guidance being provided by a number of organizations, including CMS, but certainly previous guidance, we meet or exceed those standards, and all sort of signs so far in our evaluation of the updated guidance point towards meeting those standards, if not exceeding them as well.
And another question that we're seeing is whether or not, how do you or will you adjust based on coverage of patient or group to provide auth to covered services? I'll try and rephrase that question just to make sure I'm understanding it correctly. If by adjust, what we're asking is whether or not we will require prior authorization, or if we will change what those requirements are based on the coverage or the provider. That is largely supported through the pass submission or in our user interface, supported through the actual auth submission process. So, for example, if a user selects a given member and we understand that the specific coverage type does not require prior authorization, or that they have benefits that do not require prior authorization, we prompt the user to let them know that the auth is required. That same sort of interaction occurs on the API level. So if someone were to submit an authorization to us, submit a coverage requirements discovery request to Cohere with the same context, we would reply in that response message with that context. Any other questions we can help address today? I know we've got a little bit of time left, so I'm happy to field any questions around.
Brad, Jason, it's Michael with Weedy. I got a couple of questions sent to me directly.
Yeah. Perfect.
What is the typical lift involved for implementing a CRD, DTR, PAS solution? When should my plan get started to meet the final rule deadlines?
Yeah, I would suggest that from a timing perspective, that if a plan has not started looking at vendors or interoperability solutions, now they probably should. I think I've seen a lot of presentations where the next quarter or two should be dedicated to discovery or vendor search, and I believe that given the time that it takes to implement these solutions, that sounds right. It's ahead of the 2027 deadlines. Our method for implementing these solutions is largely a data gathering phase where we retrieve the necessary information to build out our platform: patient information, provider information, policy information. And then once we go through our implementation cycle, the output of that is a CRD solution, is a DTR solution, and is a pass solution that allows us to intake and submit authorizations in that format. So essentially, if you think about it, there's the data construction layer where we built all of that information, and then there's the versatility around our endpoints to submit those requirements, submit that information, receive that the authorization data through the platform.
That's a very clean and professional way to say now, now, now.
Yes.
Got a second one. What approach do you recommend for integrating data from legacy systems that are not built on FHIR standards?
Yeah, this is a great question. What we have seen sort of throughout our 4 years as a company is the complexity around utilization management, system integration. Um, is there's a ton of variance in between payer to payer, what has been built out, and the word legacy is thrown out a lot. But another way of saying is like how long that system has been in place is a significant challenge there. So whether or not we are modifying our integration work, our integrations to um, enable workflows downstream in the utilization management system, or whether we are working as a system that's submitting information. I think where we've seen a lot of the complexity is around that to prior auth submission integration, largely because it's not simply just submitting data, right? It's around workflow enablement in the utilization management systems and ensuring that payers have what they need to kind of take that handoff and complete what needs to be done with the prior authorization, whether that's reviewing a decision, whether that's completing a decision, et cetera. So that's probably the area that we have seen the most work. And I think it's a really important point to highlight that Cohere has enabled services for other solutions like CRD to make that easier on our customers. So for example, managing those services to handle those updates around policy on a regular and recurring basis allows that submission process to be as smooth as possible.
Excellent. Thank you. Are there any other questions from the audience? Fantastic. Brad, Jason, I'll give you the final word.
Awesome. Well, want to thank everyone for taking the time out of their day. I know everyone's really busy, especially before the holiday season here. So thank you so much for your time and engagement. We look forward to the opportunity of any future discussions to see how we might be able to partner together to deliver value to patients, providers, and health plans. And wishing everyone a safe and happy holiday season. So, Jason.
Yeah, we really appreciate everybody's time and interest in the topic. As Brad and I, as you can tell, Brad and I are very passionate about this area of healthcare and how we are solving for it to provide care to patients and provide, as Brad mentioned, care at the right time, information at the right time to all of the parties involved. So thank you very much for your time. Always great talking to the Weedy group and looking forward to chatting with you all soon.
Thank you much. Brad, Jason, and the rest of the Cohere Health team, thank you very much for your support for Weedy Education. Ladies and gentlemen, we'll let you go now. Have a fantastic day. And as Brad and Jason said, happy holidays.
Thank you, everyone.